So I'll just be talking on the incidence and detection rate with uh, uh, as we can see, congenital heart disease on a global phenomena is 6.5 times more common than even chromosomal abnormalities and 4 times more common than neural tube defects. Yet, most of our effort is directed towards looking for chromosomal defects and spina bifida. Although in our country, neural tube defects may be predominating, the incidence of fetal cardiac abnormalities is so high that we should be focusing, and that's why I think this seminar is very appropriate. The other reason is that most of the abnormalities that present in the fetal stage are complex and may not go on to the neonatal stage. So that is also another important reason why fetal echo should be a focus of interest. And nearly 30% of fetuses with cardiac abnormalities may not make it in the neonatal life. If you look at the incidence, this is a very old slide. I picked up this slide for incidence from 1960s thereafter, and it shows an incidence of about 8 per thousand. And even today, the incidence is the same. About 8 per thousand is the incidence of cardiac abnormalities in the neonatal stage. So we correlate incidence with detection rate because ultimately that's the gold standard. We have an incidence of cardiac pathologies in the neonatal or infant stage, and that's where our detection should be focused at. We should match our detection rate with the incidence rate. So it's about 8%. Looking at the Indian scenario, this is probably the only paper I could find way back in 1994 from Khalil in the Indian Pediatrics, which has quoted an incidence of neonatal cardiac abnormality rate of 4, on an average about 4 per 100. And a few other papers range from 1.5 to 4. So probably our incidence of cardiac abnormalities is little lower than the world figures that we are seeing. What's interesting is that in most of these papers, none of the newborns with cardiac abnormalities had siblings or first-degree relatives with history of cardiac abnormality. So these were all new patients. There was no history of cardiac abnormality in the family. About 30% of these fetuses had associated abnormalities, specifically Down syndrome and others like CTAV and anencephaly. So the common Indian pathologies that were seen in this study was PDA and VSD. PDA, of course, as we know, can be missed on antenatal life, and VSDs can be detected. The other common abnormalities were ASD, PS, and coarctation of the aorta. And on a 6 to 18-month follow-up, about 34 to 35% of these fetuses died and did not make it. Let's look at the indications. Maternal indications, most commonly we get references of a family history. And I just said that most of the siblings did not have a cardiac abnormality in that study by Khalil et al. So majority of the indications sent for fetal indication is a family history of cardiac abnormality, and the recurrence rate is as low as 2%. This is if you take the entire spectrum of congenital heart diseases. But there are specific congenital heart diseases which have a very high incidence of recurrence, specifically the hypoplastic left heart, coarctation, cardiosplenic syndromes. These have a very high recurrence rate of almost 10%. So these should be the areas where we should focus on. If you've had 2 children with congenital heart disease in the family, then of course you have a higher incidence of having a cardiac abnormality, almost 5 to 10%. If the mother has had a cardiac abnormality, then the incidence is as high as 5 to 20%. And if the father has had a congenital heart defect, then the risk is about 3%. So this is as far as the first major indication for doing fetal echocardiography is the familial history. Then, of course, we have a whole series of maternal indicators to do fetal cardiography, and predominantly being maternal diseases like diabetes, exposure to some teratogens, like we have patients on anticonvulsant treatment or lithium for antidepressant treatment. Then exposure to prostaglandins in pregnancy is quite used, especially when we are dealing with polyhydramnios like indomethacin. Rubella is common in our situation, or parvovirus, and these could lead to cardiac abnormalities. Some mothers with autoimmune abnormalities like Sjogren's with arthritis and SLE, which can lead to conduction blocks. Or you have familial inherited disorders like the cartilage disorder, LS1-Crevall syndrome, or Noonan syndrome, that's the male counterpart of having a Turner syndrome. And that can have abnormalities. And these are the patients who should have aggressive fetal echocardiography. And the last indicator is IVF. And we have seen that there is a slightly higher incidence of having cardiac abnormality in patients who are coming from the IVF center. And specifically in the last 1 year at least, or in all IVF patients, we found about 4 Fallot's tetralogy. So that's probably one of the common pathologies that we are seeing from the IVF lab. By far the most common referral for fetal echocardiography to a specialized center would be an abnormal obstetric ultrasound. So you would have either a congenital diaphragmatic hernia or a duodenal atresia, and that may be an indicator for having that is an extracardiac abnormality. Or something is wrong with the heart, as Rabi said, and as you can see here, the heart is, there is a mesocardia, and there's probably laryngeal atresia where the heart is compressed, and there's also a cardiac abnormality. Then you look for, we are aggressively looking for chromosomal abnormalities, and the moment you find a nuchal edema or nuchal thickness, we would want to do a fetal echocardiography. Or if the heart rate is not correct, there is an arrhythmia, you look for conduction defects, and or if there is high drops and fetal anemia, we would aggressively look for cardiac abnormality. If you have multiple gestations, specifically if it's a monochorionic gestation, then we must aggressively look for the twin-twin transfusion syndrome. And as we know, the stage 3 of Quintero's classification classifies the severity of TTS on the basis of Doppler and what you see in the fetal heart. Then IUGR. We normally do a lot of Doppler for IUGR, but there could be a fetal aortic stenosis or a small VSD underlying, which could be the real cause of IUGR. So we must subject all our, at least the early IUGRs that we see, to a close look at the fetal heart. And then we have this whole new group of first trimester signs which put the fetus at high risk for doing a fetal echo, and that's specifically the nuchal, as we have seen, the tricuspid regurgitation and the ductus venosus reversal of A wave. So these are the new indications where we would do a fetal echocardiography. Then let's see how these indicators have performed over the years. And this was a study in 2001 which showed that on a 10-year experience, family history, like I said earlier, was only 2% of the reasons for referral and which detected cardiac abnormalities. The major cardiac abnormalities rested with suspicion of cardiac abnormality in a routine scan. So that's going to be the major reason for doing a fetal echocardiography when you have suspected that something is wrong. Like Ravi just said, you find that the heart is not normal and that there could be something wrong. And this is again exemplified by Lindsay Allen's study way back, where in the guys, again in the year 1990s, and where the major referral was yet congenital heart disease, which was picking up cardiac abnormalities. So 90% of cardiac abnormalities, congenital cardiac abnormalities, occur in pregnancies where there are no risk factors. So this is a big, big volume. I mean, we can understand that all the maternal and fetal indicators that I just enumerated, and we pick up a lot of cardiac abnormalities. But 90% of cardiac abnormalities will happen in mothers which are in low risk group, where there is no indication for doing a fetal echocardiography. So there is nothing like an inverted quote fetal echocardiography. Every patient that we must see should have a good fetal cardiac examination, and that's what the ISUA guidelines are talking about. So in order to detect these cases, we have to focus on the low risk group. So screening of low risk group in congenital heart disease started way back in 1986 and was introduced by the French group and then again in UK by Lindsay Allen's group, and was basically focused, like Rabi said earlier also, on the 4-chamber view. And these were some of the abnormalities that can be easily picked on the 4-chamber view. We just saw a large rhabdomyoma here. Then you have valve atresias or hypoplastic left heart. This is a hypoplastic left heart here. And the incidence of hypoplastic left heart is about 0.16 per 1,000 live births. And you can see that the left ventricle is small here as compared to that. And this is a coarctation of the aorta. You can see the narrowing of the aorta with an incidence almost similar, like 0.18 per 1,000 live births. And these are some of the other abnormalities that, if you look for, can be picked up on the 4-chamber view. You have VSDs of various types as enumerated here. You have the inlet VSD, the outlet VSD, the perimembranous VSD. And this is an inlet VSD here that you can see. That's a perimembranous VSD with the outflow tract seen here. This is an outlet VSD with Fallows. And that, of course, is the one that can be commonly missed, is the muscular VSD. So 80% fortunately are the other varieties, and about 20% will be the muscular VSD, which are commonly missed. So 0.38 per 1,000 live births is the incidence of VSDs that we see. The other common pathology is the AVSD. As Rabi just pointed out, he's yet worried that most of these abnormalities will be missed. And this is a complete AVSD, very high association with chromosomal abnormalities, almost 50%, and other extra cardiac abnormalities. And this is a balanced AVSD. This is an unbalanced AVSD, and which is associated with cardiosplenic syndrome. So here, the incidence of chromosomal abnormalities is not so high. Then you have the difficult ones, that is the partial AVSD, which may be missed because the four-chamber looks normal, or you have the severe form of ASD where there is only one AV valve and you have a single AV valve here. So these are the major forms. Then you have the valve atrasias, which form about 1 to 2% of congenital heart diseases. Here you have the tricuspid atrasia and the mitral dysplasia and the Epstein's anomaly, as we have just seen. So these are about 5 per 10,000 live births, but can be picked up on the four-chamber view. So four-chamber view is excellent in high-risk groups because you're focusing and looking at. But in the low-risk group, you have a varied. We saw a lovely chart of 92% versus 15%. So you have a range between 25 to 81%. The major drawback being that we are not looking at the outflow tracts, and that's where we miss a lot of cardiac abnormalities. So 60% is the detection rate overall on a four-chamber view. So 2 per 1,000 of the 8 per 1,000 you would pick up on the four-chamber view. And what would be the abnormalities that we would miss? Just like I said, the outflow tract. So this is a Fallot's, and this is a transposition. These are some of the outflow tract abnormalities that we would miss on the normal four-chamber. So that brings us to the focus on looking at the outflow tracts, and you have various views, and you can look at the three-vessel trachea views, sagittal views, short axis views, and the crossing over view, which is by far the most important, the last one, where the vessels cross each other, and that should be looked for. If you include the outflow tracts, we have a detection rate of almost as high as 80 to 90% of all cardiac abnormalities. So just by adding the outflow tracts, these are the abnormalities that can be picked up. So that's a Fallot's tetralogy. That's a transposition. The incidence being about 10% of congenital heart diseases is seen in Fallot's. Transposition, of course, very much lower. And then you have the double outlet right ventricle, which is not a disease by itself, but can be seen in various conditions like VSD, TOF, transposition, or the univentricular heart. So, and also one would look for the valve stenosis, the aortic and the pulmonary valve stenosis. As you can see, there is color flow is useful here to pick up turbulence. And this is an aortic arch interruption, which are less frequent. But overall, you would pick up about 3 more per 1,000 cases of congenital heart diseases if you include the great artery. So overall detection rate of about 90%. The reproducibility is good. Four-chamber view, almost 98%. Extended examination, 90%. Yet 10% of patients would need to come back for a second look at probably 24 weeks if the views are not correct. And this brings to for the third important examination protocol, that is the three-vessel view, which was originally described by you in 1997. And this pushed up the detection rate to almost 96%. And that's why I think even Rabi said that if not anything else, you should look at the three-vessel trachea view. So you look for the vessel size, the alignment, the number, and this was further propagated by Yagel in 2002, where he included the trachea. So you have the three vessels and the small white dot here with the lucency in the center representing the trachea. And these are some of the abnormalities that can be picked up on the three-vessel trachea view. So you have a small pulmonary artery here, a small aorta here, and a dilated pulmonary artery. So just by taking the sweep upwards, it's so easy to pick up these abnormalities. And then, of course, color allows us to see reversal of flow in the three-vessel trachea view, indicating that it's a ductal-dependent circulation. And this would need a proper management in the neonatal phase. So what you should do is, if you find an abnormality on the three-vessel trachea view, immediately confirm with the five-chamber view that these abnormalities are existing. Color Doppler, we have seen, has been useful for rapid visualization of flow. And that's important to look for presence or absence of flow, the flow direction, the flow pattern, and the functional aspect of abnormality. As you can see here, this is a view for the ductus venosus, and you see that white line here is showing no flow. That's the ductus venosus. So just by showing that with color that there is absence of flow in the ductus venosus here. Or for example, we have this fetus with cardiomegaly, and you have a tricuspid valve which is thick. And we don't know what is the functional aspect of the tricuspid valve. So just by adding color, we can pick up what is the direction of flow. And you can see that there is hardly any antegrade flow happening there. Most of it is regurgitating. And that's the beauty of color, which tells us, and also the pulse Doppler tells us that this is a severe tricuspid regurgitation with a dysplastic valve. So role of color Doppler would be to pick up small VSDs, blood flow patterns across the foramen ovale, which probably will be discussed a little bit later. Detection of blood flow in the great vessels and the direction in the 3-vessel view, confirming the interruption of the vena cava and cardiosplenic syndrome, difficult patients as Rabi has just shown, and of course in the first and early second trimester when you're dealing with small vessels. Now putting all these together, you have the 4-chamber view, outflow tract, you have 3-vessel trachea view, you have color. It should have been that majority of the serious cardiac malformation should have been picked up by 20 weeks. But unfortunately, the reality is that about 2% of live births have yet have fetal structural malformations. And 25% of these malformations are cardiac, 50% are serious life-threatening. And even with experienced operators, 80% of congenital heart defects will be detected and 20% go undetected. And this is because of the varying geography. So we need to have new techniques, and these are some of the new techniques. Specifically new indications for doing fetal echocardiography, and by far nuchal translucency in the first trimester is a very important indicator for us to do chromosomal analysis and fetal echocardiography. And how does it perform? Detection rate with nuchal translucency or positive nuchal edema is almost 37 to 40% if you take the 95th and 99th centiles. This compares very favorably with the 10% indications of indicators for doing fetal echocardiography, like the traditional indicators of maternal history and diabetes, etc. So this was on a meta-analysis done in 2003. So by far, I think one of the strongest indicators for doing a fetal echocardiography in the first trimester is a nuchal edema. Then 50% of major congenital heart diseases, if you see retrospectively, are associated with nuchal edema. And again, this compares very favorably with the other markers. Specifically, if you see the 4-chamber view, it's only 20% of them or varied. It varies, like I said, 20 to 80% would indicate major cardiac abnormalities. And in some studies, it goes almost to 80% of fetuses with nuchal edema have cardiac abnormalities. The next important marker in the first trimester is the tricuspid regurgitation. And this, fetuses with congenital heart diseases with chromosomal or non-chromosomal pathologies will have almost 50% of them will have tricuspid regurgitation. And as we can see here, this was a first trimester 11-week scan showing marked tricuspid regurgitation. And at 18 weeks, we could see that the pulmonary artery was small, the aorta was dilated, and this was pulmonary stenosis. So severe TR manifesting at the first trimester. Then this is another marker that I have been seeing in my practice, is that if the gestational sac is small or there's oligohydramnios, when we follow these patients up, many of them have pulmonary artery abnormalities, they have pulmonary stenosis, or for example, in this fetus, the baby had Fallot's tetralogy. Then, of course, you would look at extra cardiac malformations in the first trimester to decide which patients also would need an echo. And there, of course, the congenital diaphragmatic hernia, again seen at 14 weeks. So first trimester fetal echocardiography indications, apart from the patients who are referred with high risk, would be increased nuchal edema, abnormal flow of the ductus venosus or tricuspid regurgitation, something wrong with the sac, either a too large sac or a small sac, and of course extra cardiac lesions. And therefore, first trimester, like Rabi has just shown, echocardiography is extremely possible because of advent of new technology. So, and better informed echocardiographers. This is 11-week scan with color and B mode. You can look at the heart and the 4 chambers and the outflow tracks. Again, the 14 view scan showing the same. And then you can pick up abnormalities like the endocardial cushion defect, the single ventricle, which is one of the commonest pathologies that we find in the first trimester. And this was an interesting fetus. What we could see was calcification of the interventricular septum. This was about a 12-week scan, and the fetus had congenital aortic stenosis at 12 weeks. So these are some of the abnormalities that can be picked up. I think more and more papers will be published, and this is a 14-week scan showing Fallot's tetralogy. So fetal echocardiography, definitely possible, new indicator for doing fetal echocardiography. How does it perform? TVS in the mid-trimester detected almost 64% of abnormalities. It also missed about 17% of abnormalities. But what's important is that it picked up a large percentage of serious abnormalities as early as in the first trimester. And there are a series of papers, here again, many papers showing that at least 50 to 60% of congenital heart abnormalities can be picked up in the first trimester. Then you have new technologies which can pick up cardiac abnormalities. This is tissue Doppler imaging, which shows that there is lack of myocardial contractility in the apex of the heart. And what we are doing is vector velocity imaging for this to see that the myocardium is not contracting, again suggesting that this area is, there is myocarditis. So we have new technologies. We have STIC, which allows us to store the volumes, review the volumes, and see the volumes at a later date. So what is the accuracy? Evaluation is possible in STIC with almost 98%, but the overall sensitivity, specificity, and positive predictive value remains the same. As you're doing with sequential analysis, it's about 94 to 90%. And absolute concordance is very similar to doing a real-time examination. So STIC, although the accuracy is the same, makes for lovely pictures, for lovely volumes to be stored. And as you can see here, you can get a depth perception. You can probably pick up some abnormalities here better. There's a muscular VSD, that's a tricuspid valve which is thickened. And most of the times, a real-time examination will perform as similar to a STIC. But you definitely, it's useful for teaching, for telemedicine, for areas where there are no specialized fetal echocardiographers. And you can see that you have a small VSD, and you have different research protocols that are possible. This is a inverted mode with studies done to measure the volumes of the fetal heart. Then the planes which have been described in the ISWA guidelines can be very well seen by a single sweep on the TUI, that is the tomographic imaging, and you can see right from the stomach to the three-vessel trachea view. And sometimes you can see how that small VSD is seen only on one view. So just like a CT scan, we see the VSD on only one view, and therefore you can predict that it's a small VSD and not significant. Then you have other modalities like making the hollow chambers appear like digital casts. So this is the inversion mode. Again, good for some outflow tracts and venous abnormalities. So STIC has high degree of accuracy, albeit similar to real-time examination. It's very useful for telemedicine for areas which don't have specialists. The volumes can be stored, and if, like Rabi said, you may miss even in the expert phase 1 case, and you want to go back and review that case, and of course very useful for teaching. So putting all this in perspective, what are the reasons for detection failure? One is, of course, the differing policies of obstetric scanning in various countries. This has fortunately been now narrowed down with the ISWA guidelines, and if we follow the ISWA guidelines, then we don't have various different methods of scanning. Differing skills at scanning, we have to teach the operators the timing of the scan. Some lesions will develop in utero. The type of the lesions, some may get missed, and lesions which are undetectable, and of course, the patient's size. So skill of operator, we must remember that fetal echocardiography is, like Rabi said, is not an extension of pediatric echocardiography. Pediatric cardiographies know a little of fetal medicine and obstetric pathology, and therefore we cannot have pediatric cardiographers doing fetal echo. We have to have all of us who are doing low-risk cardiac screening doing fetal echocardiography. The spectrum of disease, as we know in fetal life, is completely different from neonatal life. So again, we are at an advantage as fetal echocardiographers to be better performing than pediatric cardiologists. If you see the skill of operator, if you have 2 experienced teachers teaching you fetal echocardiography, in this paper it is seen that the skill has risen from detection from 17% to almost 36%. And how do you improve the skill? You have high volume of patients. You maintain that skill continuously by seeing a large number of patients. Expose yourself to a large number of abnormal fetuses and have constant feedback. What's the best time to do the scan? Probably the 20 weeks in our country, 20 or around because of the limit of abortion. But for high-risk groups, we need to do a fetal echo at 12 to 14 weeks and then review at 20 weeks. We must remember that there are some cardiac pathologies which have a late onset of appearance, like endocardial fibroelastosis, rhabdomyomas, aortic stenosis, and pulmonary stenosis, and they may present late. Like for here, the rhabdomyoma presented late here. Even endocardial fibroelastic may present in the 3rd trimester. So these are not missed lesions, but they have late developments. And this was a patient of Kokwa. And there could be some small pathologies which may be missed, like a small VSD, as we are seeing here. So these could be some of the reasons. Lesions which are undetectable before birth. Ostium secundum ASD may not be detectable because it will just look like a large foramen ovale, and of course the PDA cannot be detected. So in your detection rate analysis, these two pathologies should not be included. And then of course you have the size of the patients in our country is also increasing. So you have 10% of patients in metros who are obese. You have limited resolution in some machines. Then you have fetal position at times may not be appropriate. And for example, you have an obese fetus and you don't get a view. We fortunately have harmonics, we have color Doppler, so you must utilize all the modalities to see what is better, to see the heart better. And finally, to improve the heart rate, detection rate of the congenital heart disease prenatally, you need patience, determination, experience, and we must audit ourselves. In conclusion, as I said earlier, fetal echo is not a progression of pediatric echo. It's no longer for high-risk pregnancies. And you must use high-resolution echo with Doppler and identify a large percentage of serious congenital abnormalities, at least in our country, at least by 17 or 18 weeks of pregnancy. So dedication and patience is the order of the day, and I thank you for a very, very patient hearing.